for our presentation and panel discussion on creating patient engagement portals. Today we'll be looking at approaches to collaboration, customisation and scalability. As the NHS long-term plan seeks to accelerate the redesign of patient care to future-proof for the decade ahead, we ask, what are the most effective approaches to scale digital engagement and adoption? My name's Ilse Parry, and I am the UX Research Lead for Mindwave Ventures. Mindwave is a company adept at creating patient engagement portals for the NHS and ICBs throughout England. In my role, I'm really passionate about bringing people together to learn from each other in creating a truly useful ecosystem of connectivity that motivates and empowers patients to improve their own health. The NHS long-term plan places its focus on mainstream, digitally enabled care. They speak about widespread access to empowerment tools for citizens. But how do we get patients, carers and clinicians to engage and adopt? The What Good Looks Like framework places citizen empowerment at its very core. However, when I've read through the playbooks and case studies to support its 7 measures of success, much of the implementation advice focuses on small areas of digital connectivity and procedural updates to existing tools in specific areas of healthcare. I believe this will lead to a myriad of semi-useful tools for discrete areas of health management, lacking in real transactional value for the everyday citizen. To truly empower and motivate people to engage digitally, we've got to find ways to connect all of the data together so that we can create a full and shareable picture of a person's health. For the past 6 years at Mindwave, we've been working hard to bring together everything we've learned from user-centered approaches to digital design, resulting in our modular patient engagement platform, Maya. Maya acts as an ecosystem and a customizable template to support health and well-being, bringing everything into one place. This includes EPR-connected health records, tracking tools linked to wearable devices, and tailored resources, all shareable through a circle of support. In order to create this, we've placed a lot of focus on building trusted relationships and having a flexible approach with clients, really listening to their needs and empathizing with end users. We follow a GDS-aligned process to listen to people's struggles, really, and empathize in the discovery phase. In the alpha phase, we can then adapt designs and customize the template to accommodate the needs of specific services. And in beta, we can ensure usability and accessibility through thorough user testing, creating something fully integrated, relevant, and truly useful. We believe this is the only way to achieve sustainable adoption and ultimately scalability in the mainstream. I'm now going to introduce you to our panel. We have Kumar Jacob, MBE. He's the CEO and founder of Mindwave Ventures, one of the UK's leading suppliers of patient engagement portals for the NHS. He's a leader with a highly collaborative approach to the platform development. We also have Dr. Sophie Johnson. She's a senior innovation consultant at Alderhay Children's Hospital. Sophie's partnered with Mindwave and Microsoft to develop a digital front door for children and young people. And finally, Dr. James Woolard, CCIO at Oxley's NHS Foundation Trust and National Specialty Advisor in Digital Mental Health at NHS England. In his role at Oxley's, he and his colleagues have worked closely with Mindwave to develop OxCare, one of Mindwave's first NHS patient engagement portals. I'm now going to hand over to Kumar to share his thoughts.
To just focus on a couple of aspects in terms of collaboration. Mindwave has grown all the way through collaboration. But first of all, in terms of what we have done, in addition to Maya, we are now in about 9 different trusts and ICBs. So we are in Cheshire, Merseyside, Herefordshire and Worcestershire, and another few trusts around the country. Today, we will be focusing on 2 of the relationships with Alderhay, which Sophie will expand more on, and also with Oxley's. I want to focus on what underlies good collaboration. For me and Mindwave in our 8 years, it has been relationships. It really need to create and nurture really good, strong relationships. That's the only way to have collaboration. And that needs to be at every level. It's no point my going for drinks with the CIO or having good relationship with the medical director. It has to be throughout the organization and also throughout Mindwave or any other supply organization. But to have collaboration, we need to have relationship with other suppliers. Sometimes we find that many suppliers want to work in sort of silos with the client, or client then switches over. And I think the challenges that we have are around that. Many of the systems, many of the procurement systems, many of the supplier processes means that we all want to collaborate, but then you're forced to work on a very staid supplier-client relationship. So what we need to do is to work together to actually come together and make sure that we have shared goals, understand the shared goals, understand the journey, because the journey can be long and arduous, and we need to be able to get there. And that doesn't mean we sort of bypass or get around procurement systems. I was chair of audit committee for 8 years, so I do believe in the processes and systems, but it is to make sure that we do not allow those systems to become a hindrance or a blocker to collaboration. And only from collaboration that we can go to customization and personalization, because anything that we do in digital has to ultimately end up in a personalized experience. Ilsa talked about the user. James would, I'm sure, cover points about how everything that we do in terms of digital has to be focused on the individual. And that can only happen with good collaboration and customization. Passing on to Sophie.
Thank you, Ilsa. Can you hear me? Okay. Thank you, Ilsa. Thank you, Kumar. Just make sure I'm on the right slides. So we started our journey with Mindwave in 2020, pre-pandemic, and we had evaluated our current Play app initially that was designed to make a child's experience of the hospital better. So we'd collected feedback from children and young people, parents and staff, and this digital front door concept was created. So our goal was to develop a universal centralised platform and visualisation dashboard that would enable the delivery of a new hybrid of hospital and virtual models of care, both for children and young people and clinicians. So we began with this concept, and working very closely in collaboration with Mindwave, we went on to prove this concept. So together with Mindwave, we had the opportunity to partake in a programme of work with Microsoft's commercial software engineering team. So as one team, we took this digital front door concept from a design to a technical reality by developing a creative solution called Alder Hey Anywhere. This was an intense programme of work that ran over 3 months, beginning of 2022, and resulted in a platform engine built with both a clinician and patient portal at the front end, but it also resulted in upskilling of all the team members across the 3 organisations involved, and allowed developers to then carry this project forward to a production-ready solution. So Alder Hey Anywhere is in the process of being deployed at Alder Hey Hospital to all outpatients, whilst we also explore scalability to other organisations and also for future development. So innovation is one of Alder Hey's core values, and therefore we are lucky to have a dedicated innovation team to support staff across all of our clinical divisions to tackle their problems and find innovative solutions. So we believe working in partnership with industry experts is key to achieving this change, and key to a successful partnership is having shared values such as a flexible and agile approach. Working as one team, inclusive of all factors such as time difference, language and other commitments. So if you were to join a project team meeting, you wouldn't be able to distinguish who is from each organisation. So we ensure that all projects we work on have a clinical team engaged, and part of that team is we believe that that is also really key to successful deployment to achieve the expected impact for patients. Otherwise we ask, why are we working on this project? Our strategy in Alder Hey is to have children and young people at the centre of all that we do, and that is our emotional purpose. So when we kind of explain the projects that we're working on, it's not almost what we're doing, it's why we're doing it, and then we have that kind of buy-in from all stakeholders. I think that's me done. I think hopefully that's 3 minutes.
Thank you, Sophie. I was going to try and use the mic
Oh, did I? I didn't move my slides along as well.
That's okay, don't worry.
Apologies.
That's fine, thank you. Would you like to take the stand, James? Take the stand. There you go.
The jury's out. Okay, so just to say, I am also a clinician by background. I'm a consultant child and adolescent psychiatrist, as well as being the CCIO at Oxley's, which is a mental health and community trust in South East London. We're actually on our second generation of Mindwave patient engagement platform. The first one we developed with a Health Foundation grant back in 2017, and we've been using it in my clinical team for since that time, and now we've moved over to OxCare, which is now an organizational-wide platform that we are in the foothills of rolling out to our organization. And I think I really wanted to just strip it all back and think about, what are we trying to do here? What's the basis of healthcare at the moment? And critically, it's about communication. And often where we see things go wrong is because communication has been not as good as we might hope. Whether that's, you look at complaints, you look at SUI, serious untoward incidents, you look at the amount of pharmaceutical waste that goes on, it's because we aren't communicating effectively between ourselves as healthcare professionals and our patients. So at the heart of it is communication. So really a patient engagement platform is actually just bringing that communication into the 21st century. If we look at DNA rates, I often hear from families that they haven't got their letter because the postman delivered it to the house 3 doors down because the post service doesn't work. That shouldn't happen in the 21st century when every one of the families I have on my caseload has a smartphone. So now we have, through OxCare, our appointments visible. They can log in, they can see where their appointment is. And in fact, in a session the other day, I booked an appointment on the system. Instantly, the parent could see their appointment on the system, so they had that confidence that that appointment had been booked for them. They went away. They didn't have to phone up in 2 weeks and say, oh, did Dr. Allard book that appointment because I haven't got a letter about it. So it helps us with that. So it's about changing our behaviour, not just our patients' behaviour, but our behaviour as healthcare professionals. And that behaviour change piece for healthcare professionals is the hardest part of this equation. That's what we're finding. And I really want to talk about the psychology of scarcity that traps us when it comes to adopting new ways of working and about innovation. This is from a paper that the reference is at the bottom, Psychological Responses to Scarcity by Zhao and Tom, there in Psychology magazine a few years ago. And actually, I think this, if you look at this and think about it for a while, actually every problem we have at the moment in the NHS probably comes back to some sense of scarcity thinking. And so when I go to my teams in Oxley's and say, can you think about adopting OxCare as a part of your service? No, we haven't got the time for that, Dr. Allard. We're too busy fighting fires. We've got 2-year wait list. You're saturated in the language of scarcity. We haven't got enough resource. How can we take on this? And so what we have to do is design our way out of that trap. We have to adopt user-centered design. We have to adopt service design. We use the word design in the NHS, but we don't employ designers. That needs to change. And so we have to design our way out of scarcity. But we have to, as the RSA article says, think like a system, act like an entrepreneur. I actually have started to think about, in the NHS, there are intrapreneurs and extrapreneurs. And actually, it's about creating an environment that allows intrapreneurs and extrapreneurs to work together. So what does that environment look like in terms of a pepped up ecology or ecosystem? So we have the patient. We have OxCare there as our patient engagement platform, which might have embedded a number of apps that help that person manage their wellness. We're embedding a game for anxiety into our platform for 7 to 12-year-olds as a way of trying to add value there. We're thinking about engagement with wearables, getting device data from those devices. But there might be other PEPs out there. The NHS app is a PEP. Then other services, like if we were working with Alder Hey on a national service, we might think about interoperability there. But there are other systems that we need to link into. If we have a clear mechanism for clinical safety, we can create PEPs that are essentially areas where we can innovate safely, because we've got those containers. I think of them like playgrounds where we and the patient can communicate effectively. So if we recommend an app to them, they can communicate back to us, oh, Dr. Willard, I didn't really like that app. It made me feel anxious, more anxious, not less anxious. So we need to think about this entire system and ecosystem. We can create that research. We can de-risk innovation in the NHS through this managed ecosystem. And I think that's it from me.
That's great. Thank you. Cheers, James. Thank you very much. So now I would like to invite questions from the floor to the panel. We started a little early, so I think it's 20 minutes we've got left. So does anyone have any immediate questions for anyone on the panel? Yes, please, over at the back there, just behind you.
Who's that? Is this working? Yeah.
Thank you. That's really interesting. My question is to James. So what you just said around employing user-centered design resonated with me a lot. So I'm the former director of user-centered design for NHS Test and Trace, and we obviously were designing with our users during the pandemic. What we found were that there was a lot of I'd say blockers that we were hitting with employing the methodology out across the NHS and other parts of, say, at the time, Public Health England. I'd really like to know how you have, say, broken down barriers and employed user-centered design in Oxford.
So I think what we tried to do is, and I'd say we're in the foothills of this journey. We're still kind of working on it. And I'd love to get to a point where I have a chief design officer in Oxley's who works in, or a clinical design officer, in fact, and a chief design officer. So I think we're still on our design journey. I think what it is for me is we often, going back to that scarcity thing, right, and thinking for, like, what are the pain points for our clinicians here? Because if we can unlock some of their pain points, right, some of which are self-imposed, and I could tell you about the workflows that our staff have created that actually make their jobs much harder. But I think so in therapy, you often experience your training as therapy by going through that therapy yourself. And there's a bit about which we need to help our staff by saying, let's take a user-centered design approach to your workflow. When you realize this can work for you, you'll have the confidence that you can engage with this with your patients. And think about your service design. So actually, I think we need to kind of start with heal thyself, doctor, if I can say it like that. And I think that's a challenge because immediately, like, that takes time, right? I don't have time. I've got a 2-year wait list and 3 people who are waiting 6 months to see me. If I cancel those appointments, they're going to have to wait another 3 months or whatever. I think we've got to hold our nerve. And I suppose as CCIO, my job as a leader is to say to my organization, we need to have the courage to give ourselves permission to think slowly about going faster.
What a fantastic line at the end there, James. Thank you very much. Any more questions for the panel, please? Yes, down here.
Considering one of the end users for the application is children, how was doing user testing with children? Because unlike adults, they don't do what you tell them to do.
Is this for Sophie?
Yes, really good question. But actually, it's really fun and it's really, really helpful and really actually engaging, because I know when you say, it was interesting you said that they don't do what you want them to do. Is that what you... So we are purely led by what they want and go from there. So they're almost directing us within reason. We almost have to kind of prioritise their asks and their needs, but we almost present what we did in Alder Hey with Alder Hey Anywhere is we presented them with our concept of what we'd created based on feedback from an initial kind of play app that was created as quite a standalone app back in 2014. So times moved on a lot. So it was originally created to distract, reward and familiarise children. So we presented them with this digital front door concept and they told us what they wanted. But we are still working through that with Alder Hey Anywhere now. Apologies, I hadn't clicked through to my next slide. If you could
you want me to get back?
you know, the old Hey Anywhere slide to show you the features, this one. So this is what it looks like now. At the moment, this is very much obviously a diagram version, but it's still going through iterations of testing and feedback with our patients. So we have a children and young person forum as well, which are a key stakeholder in the future development of this platform. But it's really fun. And they challenge you, which is great. Yes.
So actually, I would say children are the best people to do user acceptance testing, right? Because adults will tell you what they think you want to hear, and actually, and that's where I think UX research, like user-centered design and UX research, is really important. Go and watch people do the thing, because otherwise, if you just sit in a meeting and design a service there, you're going to get it wrong. So actually, I think children are the best people to do user acceptance testing with.
That's exactly what I was going to say, actually, James. Yeah, I don't need that. This idea of observing the participants and their natural behavior and natural responses to things. Like when I started working with Mindwave, it was a short time before the pandemic, so it wasn't really possible to be in those contextual environments with clinicians, for example. But that would be how I would generally go about doing certainly the discovery phase of understanding a clinician's needs or a parent's needs or what have you, is be in their natural environment and see how they behave and what struggles they have, not what they say they have, what you can actually see. Yeah.
If I can just come back on that. So there's a CBT, cognitive behavioral therapy-based game called Sparks, developed in New Zealand. Traditionally, we give you 1 hour a week of CBT. Right? That's the thing. And why do we do that? Because that's what we think as psychologists and psychiatrists the best dose of CBT, to have something every week for 6 weeks or 8 weeks, right? You give a game, a CBT-based game to young people, what do? They binge play it for 8 hours and do all modules at once, right? That is completely transformative in terms of thinking about how we might deliver, like testing all our assumptions about why is it that we're organizing therapy as this weekly thing. We could give people a game that they binge play for 8 hours a day. They might come back and play it for 8 hours, like in a week's time, but they've got the whole content, right? The drop-off otherwise in CBT and CBT-based apps is huge. Basically, people download them once. So those young people are telling us something about how we could do this differently.
Thank you. You want to go ahead? Yeah. Okay. Next question, please.
Hey, thank you. Super interesting talk, so thanks for all the content so far. One of the questions that we've been thinking about from Eva Health Technologies, we're building basically a new EPR in kind of primary care, or going after that kind of market, and obviously EMIS and TPP are the big players there at the moment, who some people are familiar with, and lots of people report big kind of challenges with working with them as the kind of, in inverted commas, source of truth for kind of patient information. I just wondered what your experiences have been with maintaining that source of truth for the patient, because I guess the challenge, and as the previous diagram showed, there are all these different kind of players within healthcare. So how do you make sure that the information that you're gathering and communicating with patients is also being shared across the health system, and what challenges have you had there?
Do you mean from a user experience perspective, or do you mean from a data perspective?
No, unfortunately not. It'd be a much more exciting question, I guess, if it was the user experience. I mean kind of from the data mechanisms of like the back end. So if someone rocks up at a different GP surgery, how do we find out about the information that's been shared through this product, for example?
From directly from the EPRs, you mean? How is that managed as a source of truth?
Yeah, I guess a simpler way of answering the question is like where it says EPR integration and there's an arrow between those two things. Yeah. How does that arrow work?
So that's the clinically fed data that comes via the EPR into the patient engagement platform. Now, on some of the platforms that we've produced, we've actually given patients the option of how the data is shared. It might be that some elements of customization in the platform, rather than them being customized from the data or the diagnoses that's been clinically produced in the EPR, they can choose to do it via keywords and their own about me. So something that they think is important to their health, as opposed to what sits in that EPR system. Does that answer the question?
Yeah, sort of. And then how does the stuff which is captured within the patient portal get written back, if at all?
They are starting to. So it was a struggle it was always we were able to get information from the EPRs, and I'm not going to name any today, but it was a struggle to write back. But we have now started to. So at Oxcare and Southern, we are working with Rio Mental Health Trust, where we do write back and we are able to take appointments. So it's transactional communication, as James mentioned, but it is an important part of that communication. So it can be either reviewing your appointment, or at Southern certainly you can change your appointment as well. At Alderhay, we are working with Meditech, and that will be with regard to the information that has come through from remote monitoring tools. So as you got somewhere in these boxes, the data will come through from number 5 there into the engine that we built with Microsoft and Sophie's team. And that data can now go into the EPR so that the clinicians don't have to sign into something else to see that data. That's the journey. So it is very much what is needed by the users, either the patients and carers, parents in the CYP land, or clinicians.
Just to literally add to that, so this would be like an extra layer. Alderhay would be like an extra layer to your EPR, and you say your remote monitoring device or your appointments, and this is obviously your patient engagement platform. So your EPRs are very much focused on enabling your clinicians to deliver care in that patient record.
Yeah, keep hold of it. Any further questions, please? Yes, just down here.
Whilst you're thinking of questions, if any of you wanted the slides, please see one of my colleagues who are in these green hoodies, Mindwave blazed there. If you want the slides, do ask them and we'll send it to you.
Hi, this is just a quick question about using these types of tools or this platform across borders, and how does that work with data walls? So for example, if I'm an NHS patient and abroad for 6 months, can I still use this and have access to my data?
Yes, you can, because the engagement portal itself is purely internet enabled, so it doesn't matter where in the world you are.
Okay, that's great to hear, because there are gray walls about health data across borders.
Yeah, so the data is stored within the UK, GDPR compliant and complying to everything else. But you as the consumer of the data, as a patient, it's your data and you can look at it from wherever you are set.
Super, thank you.
So I think that depends on, so we've had instances where families we've been looking after have gone on holiday and used Oxcare or the previous version of Oxcare to keep in contact with us, right? We've had families linked to the armed forces who've gone stationed abroad, and we've been in a shared care agreement with the Armed Forces Medical Corps, and we've used the app to stay in touch with, or the platform to stay in touch with them. So actually, again, that's about us as a clinical team thinking creatively about how we can use this platform to provide that continuity of care. I think that if that because the data's not moved, right? So the app hasn't moved anywhere on the internet. I think it's different if we're sending data to a different country. That is much more problematic, right? Now, I guess there's another question which sits with that. Like if I have a colleague who's working in another part of the world, and that's an increasing kind of opportunity here for digitally based kind of ways of working. We could use psychiatrists in New Zealand to provide service, and they could use the app. But again, the data doesn't move because it's still on the platform.
Thank you. One more question down here.
Hi, I'm interested in the topic of liability. And so if you're getting additional data sources coming in through these patient apps, and that's being fed into the EHR, what is your view on kind of the potential challenges with clinician liability of having to potentially act on this additional data source when potentially there isn't time for that clinician themselves to constantly be keeping on top of that data that's being fed in?
So we're still at the kind of early stages of this journey, and every device, for example, would have its own clinical care pathway. and SOT and processes that would support that. So, for example, we have a device, just saying if they are at this conference, the industry supplier, but they're not in this room, but that provides continuous monitoring of vital signs. And we've used that device through another kind of partnership to kind of prove the concept that we could have that data flowing and be presented in both of those front-end portals. The next, that is to enable the virtual ward, so like a technology-enabled care at home. So that was not to replace any current practice. So we've currently got a community care team that look after children in the community to avoid them being admitted to hospital, or also to facilitate an early discharge into this virtual ward. So that is already in place, and this platform would provide the patient front end side of things. So as things develop and as we add more devices and as we look at how we would enable further care delivery at home, things may change and develop a little bit further. But at the moment, it's not to replace anything. So with regards to the liability of clinicians being able to sit continually monitoring this data feed coming through, if that's the case, then the child should be monitored within a hospital setting. That's what we're currently doing within Alderhay.
So I'm going to use a festive analogy. If we treat these things like baubles on a Christmas tree and they're very blingy blingy, and then we're going to have a problem, right? This is why I said service design is absolutely critical. If you try and put these onto existing services, it will not work. You need to strip it back and say, how might we use the potential of patient engagement platforms to redesign and reimagine our service, right? And that's, there's lots of assumptions in that question which need to be tested. Why is it a clinician, right? How do we automate that? We look at apps like Me Too or Kooth or others. They use automated AI or machine learning, won't use the word AI, machine learning driven syntax analysis to look at what are the words here? Are there any flags that we need to, let's task shift that to a bit of machine learning, or let's task shift it to a non-clinician who can do that role. And that's what we've done a lot of in my service. So we really need to kind of pare this back and start from that design thinking. That will help us get to a redesigned Christmas tree, not just a blingy blingy bauble.
Thank you, James. And on that note, I'm going to say thank you very much for listening to us today. I've popped a little QR code onto the screen, which I encourage you to scan. We would love to continue the conversation with you. So if you did have a question that wasn't answered today, you'll find us on stand M8 downstairs. And also we have a series of different groups where you can get involved in helping us to build the future of patient engagement platforms. My colleague Chelsea is in a green jumper at the back. She's got some small business cards she can give to you to come with us on that journey. Thank you very much.